Good morning. We are going to discuss the pharmacology of local anesthetic agents. To begin, could you define a local anesthetic?
Good morning. A local anesthetic is a drug that produces reversible loss of sensation in a circumscribed area of the body without loss of consciousness. By inhibiting the generation and propagation of action potentials in excitable tissues, principally peripheral nerve fibers. The blockade is reversible, conduction-specific, and dose-dependent in the order of nerve fibers affected.
Describe the chemical structure of a clinically used local anesthetic.
All clinically used local anesthetics share a common tripartite molecular structure, a lipophilic aromatic ring, usually a benzene derivative, which determines lipid solubility and therefore potency, an intermediate hydrocarbon chain, containing either an ester or an amide linkage, which determines the metabolic pathway and the pharmacological class to which the drug belongs, a hydrophilic tertiary amine, which confers weak base properties and permits ionization in aqueous solution.
How are the local anesthetic agents classified?
They are classified by the nature of the intermediate chain into two principal groups. Esters, characterized by an ester linkage between the aromatic ring and the tertiary amine, are metabolized by plasma cholinesterase. They include procaine, chloroprocaine, amethocaine, also known as tetracaine and benzocaine. Amides, characterized by an amide linkage, are metabolized in the liver by cytochrome P450 enzymes. They include lidocaine, prilocaine, mepivacaine, bupivacaine, levobupivacaine, and ropivacaine. A useful mnemonic. Amides contain the letter I in the name before the caine suffix, lidocaine, bupivacaine, ropivacaine, while esters have a single I in the name as a whole.
Are there other useful classifications?
Yes. By duration of action. Short-acting procaine, chloroprocaine, intermediate-acting lidocaine, prilocaine, mepivacaine, long-acting bupivacaine, levobupivacaine, ropivacaine, amethocaine. By stereochemistry. Many agents are racemic mixtures of two enantiomers, bupivacaine, mepivacaine, prilocaine. Single enantiomer preparations have been developed for clinical advantage. Levobupivacaine is the pure S-enantiomer of bupivacaine, and ropivacaine is a pure S-enantiomer agent structurally related to bupivacaine. By clinical use. Agents for infiltration, peripheral nerve block, neuraxial anesthesia, intravenous regional anesthesia, and topical application.
Describe the mechanism of action.
Local anesthetics produce conduction blockade by inhibition of voltage-gated sodium channels in the neuronal cell membrane. The drug is presented in aqueous solution as an equilibrium between an unionized lipid-soluble base and an ionized water-soluble cation, the proportions governed by the Henderson-Hasselbalch equation. The unionized form diffuses across the lipid axonal membrane. Within the axoplasm, which is slightly more acidic than the extracellular fluid, the molecule reionizes, and it is the ionized cation that binds to its receptor on the inner aspect of the sodium channel pore, specifically the S6 segment of domain 4 of the alpha subunit. The drug stabilizes the channel in its inactivated state, preventing depolarization and thereby blocking propagation of the action potential.
What is meant by use-dependent block?
Use-dependent or frequency-dependent block describes the observation that local anesthetic binding is enhanced in rapidly firing nerves. The sodium channel exists in three conformational states: resting, open, and inactivated. The drug binds preferentially to the open and inactivated states. In rapidly depolarizing fibers, the channels spend a greater proportion of time in these states, exposing more binding sites, so blockade develops more readily. The clinical correlate is that pain-conducting fibers, which fire at high frequency, are blocked at lower drug concentrations than fibers serving slower conducting modalities.
Explain differential block.
Differential block describes the selective inhibition of different nerve fiber types in a defined sequence, dependent on diameter, myelination, and firing frequency. The order of blockade is B fibers first, small myelinated preganglionic sympathetic fibers, then C fibers, small unmyelinated, conveying slow pain and postganglionic sympathetic activity, then A delta, small myelinated, conveying fast pain and temperature, then A gamma, motor to muscle spindles, then A beta, light touch and pressure, And finally A-alpha, large, heavily myelinated, conveying motor and proprioceptive information. Recovery occurs in the reverse order. Clinically, this explains why sympathetic blockade and analgesia precede sensory and motor loss, and why motor function returns before sensation.
Why are B fibers blocked first if they are not the smallest?
Because myelination concentrates the local anesthetic effect at the nodes of Ranvier, and B fibers are both myelinated and small in diameter. The combination of small fiber size with myelination produces preferential blockade. C fibers, though smaller, are unmyelinated and require blockade over a longer continuous length of axon, which makes them slightly more resistant.
What property of a local anesthetic determines onset of action?
The pKa. The pKa is the pH at which 50% of the molecules are ionized and 50% unionized. The closer the pKa is to physiological pH of 7.4, the higher the proportion of unionized drug available to cross the nerve membrane, and the more rapid the onset. Agents with pKa closer to 7.4, such as lidocaine and mepivacaine, have faster onset than agents with higher pKa such as procaine.
What determines potency?
Lipid solubility, expressed as the octanol-to-water partition coefficient. The more lipid-soluble the molecule, the more readily it traverses the lipid axonal membrane, and the smaller the dose required for a given effect. Highly lipid-soluble agents, bupivacaine, levobupivacaine, amethocaine, are used at concentrations of 0.25 to 0.5%. Less lipid-soluble agents such as lidocaine require concentrations of 1 to 2% for equivalent blockade.
What determines duration of action?
Protein binding, both to alpha-1 acid glycoprotein and albumin in plasma, and to membrane proteins at the receptor site. The greater the affinity for protein binding, the longer the molecule resides at the channel, and the longer the duration of clinical effect.
Summarize.
pKa determines onset, lipid solubility determines potency, protein binding determines duration. These three relationships form the core framework for understanding any local anesthetic agent.
Contrast the metabolism of esters and amides.
Esters are hydrolyzed in plasma by pseudocholinesterase, also termed butyrylcholinesterase, and to a lesser extent in the liver. Plasma half-lives are short, minutes, and clearance is rapid. One metabolite of several esters is para-aminobenzoic acid, or PABA, which is implicated in the higher incidence of allergic reactions seen with this class. Plasma pseudocholinesterase deficiency, though uncommon, prolongs the duration and elevates plasma concentrations. Amides are metabolized in the liver by cytochrome P450 enzymes, principally CYP3A4 and CYP1A2, through N-dealkylation and aromatic hydroxylation. Half-lives are longer, typically 90 minutes to several hours, and metabolism is reduced in hepatic dysfunction, reduced hepatic blood flow, and with co-administered enzyme inhibitors. Allergic reactions to amides are genuinely rare and are usually attributable to preservatives, not to the parent compound.
Are there exceptions to this classification?
2. Prilocaine is metabolized partly in the liver, partly in the kidneys, and partly in the lungs. Its hepatic metabolite, orthotoluidine, oxidizes hemoglobin to methemoglobin and is the basis of dose-related methemoglobinemia. Benzocaine, an ester used topically, similarly causes methemoglobinemia.
What determines systemic absorption from a regional block?
4 factors: the vascularity of the site of injection, the total dose administered, the physicochemical properties of the agent, particularly lipid solubility and protein binding, the addition of vasoconstrictor, which delays absorption. The hierarchy of absorption from common sites in descending order follows the mnemonic ICE, BA-LL. Intercostal, caudal, epidural, brachial plexus, axillary, lower limb, local infiltration. Peak plasma concentrations after amide injection typically occur at 15 to 30 minutes.
What adjuncts are used with local anesthetics and why?
Several. Adrenaline, added in concentrations of 1 in 200,000 to 1 in 80,000. It produces local vasoconstriction, which reduces systemic absorption, prolongs duration of block, and lowers peak plasma concentration. It serves as a marker of intravascular injection, indicated by a tachycardia or hypertensive response of 15 beats per minute or 15 millimeters of mercury within 30 seconds. And it improves block quality with shorter-acting agents. Sodium bicarbonate, 8.4%, 1 milliliter per 10 milliliters of solution, shifts the equilibrium towards the unionized form, accelerating onset, particularly for lidocaine with adrenaline. Clonidine, an alpha-2 agonist, 75 to 150 micrograms, prolongs block and provides additional analgesia. Dexamethasone, perineural or intravenous, prolongs block duration by 20 to 50% without evidence of neural injury at clinical doses. Opioids, fentanyl, sufentanil, morphine, added to neuraxial blocks, prolong sensory block without prolonging motor block.
When should adrenaline be avoided?
In end arterial circulations, historically the fingers, toes, penis, ears and tip of nose, though contemporary evidence has challenged this prohibition for digital blocks. In uncontrolled hypertension or unstable cardiac disease, in patients receiving monoamine oxidase inhibitors or tricyclic antidepressants, where the cardiovascular response to sympathomimetics is exaggerated. In intravenous regional anesthesia, where adrenaline confers no benefit and adds risk on tourniquet release.
Now take me through the principal local anesthetic agents in turn, with their pharmacological properties and clinical uses. Begin with the esters.
Procaine was the first synthetic local anesthetic, introduced in 1904. Classification: ester. pKa 8.9, substantially above physiological pH, conferring a slow onset. Lipid solubility: low, partition coefficient approximately 100, therefore low potency. Protein binding: approximately 6%, therefore short duration, typically 45 to 60 minutes. Metabolism: rapid hydrolysis by plasma pseudocholinesterase to paraaminobenzoic acid. Maximum dose: 10 to 12 mg per kilogram. Clinical use: now largely of historical interest, occasionally used for infiltration. Superseded by lidocaine in essentially all applications. Adverse effects: relatively high allergic potential due to the P-A-B metabolite.
Chloroprocaine.
Chloroprocaine is a chlorinated derivative of procaine, introduced to overcome procaine's slow onset and low potency. Classification: ester. pKa 8.7, still above physiological pH, but used at high concentration, 2 to 3%, which generates sufficient unionized drug to achieve rapid onset. Lipid solubility: low, but the high concentration compensates. Protein binding: low, therefore short duration, 30 to 60 minutes. Metabolism: extremely rapid hydrolysis by plasma pseudocholinesterase, with the shortest half-life of any local anesthetic, approximately 20 seconds. Maximum dose: 11 mg per kilogram or 14 with adrenaline. Clinical use: increasingly used for short-duration spinal anesthesia in ambulatory surgery, the rapid metabolism allows fast recovery and discharge. Also used for epidural top-up where rapid onset is required, particularly in obstetrics. Adverse effects: historical reports of neurotoxicity were attributed to a preservative, sodium bisulfite, which has been removed from modern preparations. Current preservative-free formulations are considered safe.
Amitrocaine.
Amitrocaine, also known as tetracaine, is a long-acting ester. Classification: ester. pKa 8.5, onset is moderate to slow. Lipid solubility: very high, partition coefficient approximately 5,000, therefore high potency. Protein binding: high, approximately 75%, therefore long duration, 2 to 3 hours and beyond. Metabolism: hydrolyzed by plasma pseudocholinesterase, more slowly than other esters. Maximum dose: 1.5 mg per kilogram. Clinical use: principally topical, 4% gel marketed as imetop for skin anesthesia prior to venipuncture or cannulation, particularly in pediatrics. It provides skin anesthesia within 30 to 45 minutes and produces vasodilation, which is helpful for cannulation. Also used historically in ophthalmology and rarely for spinal anesthesia. Adverse effects: local erythema and edema at the site of application, allergic reactions reported but uncommon.
Benzocaine, a brief mention.
Benzocaine is a topical ester, used primarily in proprietary throat lozenges. and over-the-counter preparations for oral and pharyngeal mucosal anesthesia. Classification Ester. pKa, low 3.5 and largely unionized at physiological pH, which permits rapid mucosal penetration, but limits systemic absorption from intact mucosa. Clinical use, limited in anesthetic practice. Relevant principally because of its association with methemoglobinemia, particularly when used for topical airway anesthesia in adults and in any dose in neonates and infants.
Now the amides, lidocaine.
Lidocaine is the prototype amide local anesthetic and the most widely used in clinical practice. Introduced by Lufgren and Lundqvist in 1943. Classification amide. pKa 7.9, close to physiological pH, conferring rapid onset within 2 to 5 minutes. Lipid solubility. Moderate partition coefficient approximately 350, therefore intermediate potency. Protein binding. 64%, therefore intermediate duration, typically 60 to 90 minutes plain and up to 2 hours with adrenaline. Metabolism. Hepatic by N-dealkylation to monoethylglysanksilidide and glysanksilidide, both of which retain some pharmacological activity. Maximum dose, 3 mg per kilogram plain, 7 mg per kilogram with adrenaline. Clinical use. Extensively used for infiltration, peripheral nerve blocks, intravenous regional anesthesia, Beers block, epidural anesthesia, topical airway anesthesia, and as an intravenous antiarrhythmic for ventricular arrhythmias. Intravenous lidocaine infusion at 1 to 1.5 mg per kilogram per hour is increasingly used as an opioid-sparing analgesic adjunct in major abdominal surgery. Adverse effects. Dose-dependent CNS and cardiovascular toxicity at high plasma concentrations. Transient neurological symptoms following hyperbaric spinal lidocaine in lithotomy position, which has reduced enthusiasm for its use intrathecally.
Prilocaine.
Prilocaine has the lowest acute systemic toxicity of the commonly used amides, and is favored for that reason in specific applications. Classification amide. pKa 7.9, rapid onset, comparable to lidocaine. Lipid solubility. Moderate partition coefficient approximately 129. Protein binding, approximately 55%, therefore intermediate duration, 60 to 90 minutes. Metabolism, hepatic, but with significant extrahepatic metabolism in the kidneys and lungs. Hepatic metabolism produces orthotoluidine, which oxidizes hemoglobin to methemoglobin. Maximum dose, 6 mg per kilogram, or 8 with adrenaline, with an absolute ceiling of 600 mg in an adult to mitigate methemoglobinemia risk. Clinical use. The agent of choice for intravenous regional anesthesia, owing to its rapid metabolism and low cardiotoxic potential, should the tourniquet fail. Hyperbaric 2% prilocaine, marketed as Prilotacal, is widely used for short-duration day-case spinal anesthesia, providing a predictable block of approximately 90 minutes with rapid recovery. Also used in EML cream, in combination with lidocaine. Adverse effects. Methemoglobinemia is the characteristic and dose-related adverse effect. Avoided in neonates and in patients with congenital methemoglobinemia or significant cardiopulmonary disease where impaired oxygen-carrying capacity would be poorly tolerated.
Mepivacaine.
Mepivacaine is an amide of intermediate potency and duration. Classification amide. pKa 7.7, rapid onset. Lipid solubility. Moderate partition coefficient approximately 130. Protein binding. 78%, therefore intermediate to long duration, 90 minutes to 3 hours. Metabolism, hepatic, similar to lidocaine. Maximum dose, 4 mg per kilogram, 7 with adrenaline. Clinical use, widely used in dental anesthesia and peripheral nerve blocks, particularly in continental European practice. Less popular in UK regional anesthesia, where lidocaine and the long-acting agents dominate. Adverse effects, similar profile to lidocaine, not associated with methemoglobinemia.
Bupivacaine.
Bupivacaine is the principal long-acting amide local anesthetic, introduced in 1963. Classification, amide, a racemic mixture of R and S enantiomers. pKa, 8.1, moderate onset, 10 to 20 minutes. Lipid solubility. High partition coefficient over 3000, therefore high potency, used at 0.25 to 0.5%. Protein binding, 95%, therefore long duration, 4 to 8 hours in peripheral nerve blocks. Metabolism, hepatic by endochelation. Maximum dose, 2 mg per kilogram, irrespective of adrenaline. Clinical use, the workhorse of long-duration regional anesthesia. Used for peripheral nerve blocks, plexus blocks, epidural anesthesia and spinal anesthesia, available in plain and hyperbaric formulations, particularly suited to surgery requiring prolonged post-operative analgesia. Adverse effects. Cardiotoxicity is the principal concern. The R enantiomer binds tightly to cardiac sodium channels, described as fast-in, slow-out kinetics, with cumulative blockade at fast heart rates and resistance to resuscitation. Bupivacaine-related cardiac arrest is characteristically refractory and was the original indication for intravenous lipid emulsion rescue. The drug also impairs mitochondrial fatty acid oxidation, compounding the cardiotoxic profile.
Levobupivacaine.
Levobupivacaine is the pure S-enantiomer of bupivacaine, developed in response to the cardiotoxicity of the racemic preparation. Classification: amide, single S-enantiomer. pKa 8.1, comparable to bupivacaine. Lipid solubility: high, comparable to bupivacaine. Protein binding: 97%, slightly higher than racemic bupivacaine. Metabolism: hepatic. Maximum dose: 2 mg per kilogram, in line with bupivacaine. Clinical use. Indications and concentrations are essentially identical to those of bupivacaine, peripheral nerve blocks, epidural and spinal anesthesia, and the clinical effects are pharmacologically indistinguishable in most settings. Adverse effects. Approximately 30% reduction in CNS and cardiovascular toxicity compared with racemic bupivacaine in animal models and clinical observation. The threshold dose for arrhythmia and seizure is higher. In jurisdictions where it is available, including the UK and much of Europe, it has substantially replaced racemic bupivacaine for high-volume regional techniques.
Ropivacaine.
Ropivacaine is a long-acting amide developed concurrently with levobupivacaine as a safer alternative to bupivacaine. Classification: amide, single S-enantiomer, structurally similar to bupivacaine but with a propyl rather than butyl substituent on the piperidine ring. pKa 8.1, moderate onset. Lipid solubility: lower than bupivacaine, partition coefficient approximately 775, therefore slightly lower potency, though clinically very similar. Protein binding: 94%, long duration 4 to 6 hours. Metabolism: hepatic. Maximum dose: 3 mg per kilogram, marginally higher than bupivacaine. Clinical use: extensively used for peripheral nerve blocks, plexus blocks and epidural anesthesia, particularly favored for postoperative epidural and continuous catheter techniques. Adverse effects: substantially reduced cardiotoxic potential compared with bupivacaine, attributed to its single enantiomer composition and lower lipid solubility. A clinically useful property is differential blockade with relative motor sparing. Sensory block at low concentrations with comparatively preserved motor function, which makes it well suited to obstetric epidural analgesia and ambulatory regional techniques.
What topical preparations are in routine clinical use?
3 principal preparations. EML, a cream, the eutectic mixture of local anesthetics, is a 1-to-1 combination of 2.5% lidocaine and 2.5% prilocaine. A eutectic mixture has a melting point lower than that of its individual components, allowing the active drugs to exist as a liquid at room temperature and to be formulated at higher effective concentration in an emulsion, applied under an occlusive dressing for 60 minutes for venipuncture or cannulation, and for 90 minutes or more painful procedures. Amethocaine 4% gel, marketed as iMetop, applied for 30 to 45 minutes, providing faster onset than EML and producing local vasodilation, which is advantageous for cannulation. Lidocaine in spray, gel and viscous oral formulations, used principally for topical airway anesthesia in awake intubation, in nasal procedures, and in upper gastrointestinal endoscopy. Mucosal absorption is rapid and unpredictable. Total dose must be calculated and limited to within safe systemic limits.
We now move to toxicity. Take me through local anesthetic systemic toxicity.
Local anesthetic systemic toxicity, LOST, is the syndrome of central nervous system and cardiovascular toxicity that results from excessive plasma concentrations of local anesthetic. The reported incidence is approximately 1 per 1,000 peripheral nerve blocks, lower with neuraxial techniques, and substantially lower with the routine use of ultrasound guidance and incremental injection.
What are the principal causes?
3. Inadvertent intravascular injection, the most common and the most dangerous, producing immediate high plasma concentrations. Administration of an excessive total dose that exceeds the maximum safe dose for the agent and patient. Rapid systemic absorption from a highly vascular site, particularly intercostal, paracervical, head and neck, and tracheal blocks. Risk is increased in extremes of age, low body weight, pregnancy, hepatic and cardiac dysfunction, hypoxia and acidosis, each of which raises the free fraction of drug or impairs clearance.
Describe the clinical presentation.
The classical sequence is CNS toxicity, followed by cardiovascular toxicity. Although with bupivacaine, the two may occur simultaneously without warning. Early CNS features: perioral numbness, tinnitus, metallic taste, visual disturbance, lightheadedness, slurred speech, agitation. Excitatory CNS features: muscle twitching, generalized seizures, loss of consciousness. Depressed CNS features at very high concentrations: coma and respiratory arrest. Cardiovascular features: initially hypertension and tachycardia from CNS excitation, thereafter progressive hypotension, bradycardia, conduction block, ventricular arrhythmias, and a systolic cardiac arrest.
How is LOST prevented?
Several measures. Calculation of the maximum safe dose based on lean body weight, before injection. Use of the lowest effective concentration and volume. Aspiration before injection, and aspiration every 5 milliliters during incremental injection. Slow injection, no faster than 10 to 15 milliliters per minute. Ultrasound guidance for peripheral blocks, which reduces both intravascular injection and total dose required. Test dose with adrenaline-containing solution before epidural or major peripheral block. Continuous verbal contact with the patient to detect early symptoms. Ensuring that 20% intravenous lipid emulsion is immediately available in any area where regional anesthesia is performed.
Now the management of established LOST.
I would follow the triple AGBI safety guideline. First, recognition and immediate cessation of injection. Second, call for help including the cardiac arrest team and request 20% intravenous lipid emulsion. Third, airway and ventilation. Secure the airway and administer 100% oxygen. Prevention of hypoxia and acidosis is critical, as both worsen toxicity. Fourth, seizure control. Small incremental doses of benzodiazepine, midazolam 2 to 5 milligrams, or low-dose thiopentone or propofol, with caution as the latter may compound cardiovascular depression. Fifth, circulatory support. Cardiopulmonary resuscitation if cardiac arrest has occurred. Continued for as long as is necessary, since successful resuscitation has been reported after more than an hour. Adrenaline is used at reduced doses, initial boluses of 1 microgram per kilogram, rather than the standard 1 milligram, because higher doses appear to reduce the efficacy of lipid rescue and worsen acidosis. Amiodarone is the preferred antiarrhythmic. Vasopressin, calcium channel blockers, beta blockers, and other local anesthetics are avoided.
Describe the lipid emulsion regimen.
20% intravenous lipid emulsion, intralipid, is the specific therapy. The triple AGBI dosing regimen. An initial bolus of 1.5 milliliters per kilogram of lean body mass over 1 minute, followed by an infusion at 15 milliliters per kilogram per hour. The initial bolus may be repeated up to 2 further times at 5-minute intervals if cardiovascular instability persists, and the infusion rate may be doubled to 30 milliliters per kilogram per hour if hypotension continues. The total maximum cumulative dose is 12 milliliters per kilogram. The proposed mechanism is the lipid sink, providing a lipid compartment into which the highly lipid-soluble drug redistributes, away from cardiac sodium channels, supplemented by a metabolic effect on cardiac mitochondrial fatty acid oxidation.
And subsequent care.
Continued lipid infusion for at least 10 minutes after circulatory stability. Admission to a critical care environment for at least 12 hours, owing to the risk of recurrence as redistribution kinetics evolve. Plasma sample for local anesthetic concentration for retrospective interpretation. Incident reporting to the national system and to the GBI registry. Team debriefer.
Confirm the maximum doses for the agents we have discussed.
Per kilogram of lean body weight. Lidocaine 3 mg per kilogram plain, 7 mg per kilogram with adrenaline. Bupivacaine 2 mg per kilogram, irrespective of adrenaline. Levobupivacaine 2 mg per kilogram. Ropivacaine 3 mg per kilogram. Prilocaine 6 mg per kilogram plain, 8 with adrenaline. Absolute ceiling of 600 mg in an adult. Mepivacaine 4 mg per kilogram plain, 7 with adrenaline. Amisocaine 1.5 mg per kilogram. Procaine 10 to 12 mg per kilogram. Chloroprocaine 11 mg per kilogram plain, 14 with adrenaline.
Calculate the maximum permissible volume of 1% lidocaine without adrenaline for a 70 kg adult.
1% solution contains 10 mg per milliliter. Maximum dose at 3 mg per kilogram is 210 mg. Maximum volume is therefore 21 milliliters.
And for 0.5% bupivacaine.
0.5% contains 5 mg per milliliter. Maximum dose at 2 mg per kilogram is 140 mg. Maximum volume is therefore 28 milliliters.
What dose modifications would you apply in specific patient groups?
For the elderly, reduce doses by approximately 20 to 30% owing to reduced clearance, lower lean body mass, and reduced protein binding from hypoalbuminemia. Pregnancy, epidural and intrathecal dose requirements are reduced by 20 to 30%, owing to engorged epidural veins, hormonally mediated increased neural sensitivity, and altered protein binding. Neonates and infants, reduced alpha-1 acid glycoprotein and albumin, immature hepatic metabolism, larger volume of distribution, doses calculated per kilogram with a lower ceiling. Prilocaine is avoided in neonates because of methemoglobinemia risk. Hepatic dysfunction, reduced clearance of amides. Use lower doses and avoid repeated bolus or infusion regimens.
Comment on allergy to local anesthetics.
True allergy is uncommon and frequently misdiagnosed. Reactions reported as allergy are most often vasovagal episodes, sympathetic responses to adrenaline-containing solutions, or reactions to preservatives, particularly methylparaben and sulfites. When genuine allergy occurs, it is markedly more common with esters owing to the para-aminobenzoic acid metabolite. There is no cross-reactivity between esters and amides. A patient with a documented ester allergy may safely receive an amide preparation. Suspected allergy warrants formal investigation by skin prick and intradermal testing, ideally under specialist immunology supervision.
Methemoglobinemia, diagnosis and treatment.
Methemoglobinemia is the accumulation of hemoglobin in which the iron has been oxidized from the ferrous to the ferric state, rendering it incapable of binding oxygen. The relevant agents in local anesthetic practice are prilocaine and benzocaine. Diagnosis: the patient appears cyanosed despite a normal arterial PaO2. The arterial blood appears chocolate brown. The pulse oximeter reads falsely at approximately 85% regardless of true saturation, because methemoglobin absorbs red and infrared light approximately equally. Definitive diagnosis is by co-oximetry of an arterial blood gas sample. Treatment: discontinue the offending agent, administer 100% oxygen, and give methylene blue at 1 to 2 mg per kilogram intravenously over 5 minutes, repeated at 1 hour if required, to a maximum of 7 mg per kilogram. Methylene blue acts as an electron acceptor, reducing methemoglobin to hemoglobin via the a DPH-dependent methemoglobin reductase pathway. Methylene blue is contraindicated in glucose 6-phosphate dehydrogenase deficiency, where ascorbic acid or exchange transfusion may be required.
Cauda equina syndrome and transient neurological symptoms.
Cauda equina syndrome is a constellation of saddle anesthesia, lower limb weakness, and bladder and bowel dysfunction caused by injury to the nerve roots of the cauda equina. In local anesthetic practice, it has been associated with continuous spinal anesthesia using microcatheters delivering hyperbaric 5% lidocaine, where pooling of high-concentration drug in the dependent sacral region caused neurotoxicity. This led to the withdrawal of microcatheters from many markets and to caution with intrathecal high-concentration lidocaine. A related entity, transient neurological symptoms, describes self-limiting buttock and lower limb pain following spinal lidocaine, particularly in the lithotomy position. The syndrome is uncommon with current practice using bupivacaine or hyperbaric prilocaine.
Intravenous lidocaine as an analgesic adjunct. What is the rationale?
Intravenous lidocaine is increasingly used as an opioid-sparing analgesic adjunct in major surgery, particularly laparoscopic and open abdominal procedures. The mechanism is multifactorial: sodium channel blockade at multiple sites, anti-inflammatory effects through reduction of cytokine release, modulation of NMDA receptor activity, and attenuation of central sensitization. The typical regimen is a bolus of 1 to 1.5 milligrams per kilogram at induction, followed by an infusion of 1.5 milligrams per kilogram per hour intraoperatively, continued for up to 24 hours postoperatively. Evidence supports reduced opioid requirement, faster return of bowel function, and shorter hospital stay in appropriate populations. Contraindications include significant arrhythmia, second or third degree heart block, severe hepatic dysfunction, and concurrent administration of other local anesthetic agents whose cumulative dose might approach toxicity.
Tumescent anesthesia. Describe it.
Tumescent anesthesia is the technique used principally in liposuction and certain plastic surgical procedures, in which large volumes of dilute lidocaine, 0.05 to 0.1%, with adrenaline at 1 in 1 million, are infiltrated into the subcutaneous tissues. Total lidocaine doses well in excess of conventional maxima, up to 55 milligrams per kilogram, have been administered, with safety attributed to slow systemic absorption from the avascular, vasoconstricted tissue. Peak plasma concentrations are delayed for several hours. Fatalities from systemic toxicity have nonetheless been reported, particularly when the technique is combined with general anesthesia. The technique requires strict adherence to protocol and prolonged postoperative observation.
Pediatric caudal anesthesia. A brief comment.
Caudal anesthesia is the most widely used pediatric regional technique. A single injection of 0.25% bupivacaine or levobupivacaine at 0.5 to 1 milliliter per kilogram provides analgesia for surgery below the umbilicus, most commonly circumcision, inguinal hernia repair and orchidoxy. The maximum dose is the standard 2 milligrams per kilogram. Adjuncts including preservative-free morphine, clonidine, or ketamine may prolong analgesia, although morphine carries a recognized risk of delayed respiratory depression and mandates appropriate monitoring.
5 take-home messages on local anesthetic pharmacology.
1. 3 properties, 3 determinants. The pKa determines onset, lipid solubility determines potency, protein binding determines duration. Every clinical property of every local anesthetic flows from these 3 relationships. 2. The unionized form crosses the membrane. The ionized form blocks the channel. This explains why tissue acidity slows onset, why infected tissue is difficult to anesthetize, and why alkalinization accelerates onset. 3. Know the maximum doses with confidence. 3 milligrams per kilogram for plain lidocaine, 7 with adrenaline, 2 milligrams per kilogram for bupivacaine and levobupivacaine, 3 for ropivacaine, 6 for prilocaine with a 600 milligram ceiling. 4. Local anesthetic systemic toxicity is a foreseeable, preventable and treatable emergency. Lipid emulsion at 1.5 milliliters per kilogram bolus and 15 milliliters per kilogram per hour infusion, reduced dose adrenaline, prolonged resuscitation, critical care admission afterwards. 5. True allergy is rare. Methemoglobinemia and bupivacaine cardiotoxicity are real. Treat suspected allergy with appropriate skepticism but proper investigation. Recognize methemoglobinemia and treat with methylene blue, observing the G6PD caveat. and respect bupivacane's cardiotoxic profile by preferring ropivacaine or levobupivacaine where the clinical indication permits.
Thank you. That concludes this station.